Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hi, I'm Dr. Jack West, and I'm an Associate Clinical Professor in Medical Oncology at the City of Hope Comprehensive Cancer Center, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm very happy to be joined today by two of my colleagues who are also on the board of directors for GRACE and have long been committed to patient education. And so I'd like to introduce and have them give details on their own positions. First, Dr. Jared Weiss, if you can say a bit about yourself.
Sure, I'm Jared Weiss. I'm an associate professor of medicine at University of North Carolina's Lineberger Comprehensive Cancer Center, where it's a privilege to take care of patients and run trials in lung cancer.
And also Dr. Ben Levy.
Yeah, I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. And like Jared, it's a pleasure to take care of lung cancer patients and deliver hopefully great care and great science to these patients.
Excellent. We're here today to give an update on where we are in the battle against coronavirus and also the implications of coronavirus in our own treatment of lung cancer and potentially other cancers. Telemedicine isn't going to go away and shouldn't go away, but it's not the right tool for every job, and that it is well suited for some patients, and that is dictated in part by their acuity. Some of our patients, the visits are more of a ritual, and I think that one thing that coronavirus concerns has forced us to do in a good way has been to look carefully at what we're doing and pare down the things that are not as necessary. That we need to get labs every few weeks, and can we space these out, and can visits be virtual instead of in real life? In other cases, we might, as you have, to find that, there is some incremental benefit to the patient coming in this particular case, or there are barriers, whether that is bandwidth, hardware, or technical ones. So the fact is that patients are largely older. Lung cancer, the median age is at diagnosis a little over 70, and some patients may not have the technical ability to navigate some of the more cumbersome so-called solutions out there that require what would seem like a team of IT specialists to get into the virtual exam room. So I think we do recognize that. That said, I'm practicing at City of Hope, where we have a lot of patients who are getting stem cell transplants and CAR T, which is a long treatment. And I think one of the challenges that we haven't paid a lot of attention to, and it may not apply as much in lung cancer as some other cancers, is the restriction on visitors, whether it's outpatient or inpatient. We have really clamped down on that, and I think it's a hardship for some patients, even just having someone in the family come in to accompany them. We are not allowing that, with very rare exceptions. And virtual visits do allow that possibility, and that's one of the reasons that some of my patients prefer a virtual visit, because they can have one or several people around them when we don't have that facility if they're coming in live. I'm interested, Ben, can you offer your thoughts here about, and then I'd like to also get Jared's thoughts on just what proportion of patients, how that balance might work out in your own practice. I think it's going to vary from doc to doc and the region and various things like that, but I think that they should coexist in the long term. Ben?
Well, I can give you the exact numbers because we just ran them.
Okay.
We're in DC, we're around 70-30, 70% telemedicine, 30% in person. In Baltimore, it's around 50-50. And at Bayview and Green Spring, which are two other parts of the health system, it's around 50-50, or even at Green Spring, around 70-30 the other way.
Wow.
In-person visits versus telemedicine. We just had a meeting about this. I want to echo some of Jared's sentiments, and we are in what we call this reanimation phase. I don't know if this is something that's termed by Hopkins or not, but this is where we're really trying to make a push to bring patients back in a meaningful and a careful way. And I do agree, Jack. I think there is a role for telemedicine, and it's not a one-size-fits-all model. I have been surprised, as much as I take pride in my bedside manner, my webside manner is just the ability to have the conversations are different over telemedicine as they are in person. And I think I said this, the last time, the things that go down on that one-on-one meeting in a physical space may be very different than the things that go down in a virtual space, specifically for new patients. I've had some challenges with new patients and creating that rapport and getting a rhythm going so we can get treatments going. So and if we look again, similar to Jared, what Jared said, and something that you said too, if we look at our in-hospital transmission rate, it's 0. If the right metrics are put in place and they're followed. So mask wearing, temperature taking, all of the things that Jared mentioned we're doing as well. And I do think we can bring people back in a safe and meaningful way, with some caveats that if patients or physicians don't feel comfortable, we can do telemedicine visits for those patients. And there's still those that, even outside of COVID, that probably will. I think this will change medicine altogether. But we are still around, depending on the site you look at Hopkins, 50-50 or 70-30. I'm hopeful that we're making these decisions based on our own numbers, which continue to go down. And if we have another one of these in 4 weeks, maybe I'll say something different. But we are in a process of trying to bring more patients back. We have found major gaps in care through telemedicine. We may not have been as savvy as City of Hope and others like you, Jack. This is brand new to us for the most part. And so we're learning this, and we've had some challenges. And again, I want to have a balanced message here. I think that, yes, there are some cases where telemedicine is very reasonable and will continue to do so. But I think that we're learning the challenges, and that things are falling through the cracks at times when this is going on. And because of that, we're trying to make a more meaningful effort to bring folks back in person with the right precautions.
A couple.
Jack, you had brought up the contrast to head and neck, and it's been instructive to me. My average lung cancer patient is a stage 4 patient who unfortunately I can't cure, and I'm treating for the goals of preserving quality of life and duration of life. My average head and neck cancer patient, as you referenced, it's true, I'm doing rather aggressive things too, but for a goal of cure. And the human math of what a person's willing to go through when there's cure and decades of quality of life on the other side isn't really our subject today. But what I do want to speak to is that I'm seeing a stage migration in head and neck that is really disturbing to me. There was a period where I was pretty much not seeing new patients, not by my choice. No one was coming in. And on the other side of that now, with a reanimation, as Ben put it, I'm seeing less local stage head and neck, less local regional head and neck, and more incurable head and neck. And I'm very disturbed by that because the loss of an opportunity to cure is tragic, right? You don't lose months of quality life, you lose years to decades, and with suffering in between. So if I had one message to offer, it's that with the data that we now have on the lack of transmission with appropriate precautions, that patient, if a patient feels a lump in his or her neck, trouble swallowing, trouble speaking, symptoms of head and neck cancer, there is not a substantial risk to going to get appropriate evaluation with precautions, and it very much should be done.
And without losing that window of potential opportunity. Yeah. Let me just ask, and it may be a quick answer, but one thing I would say is that with regards to telemedicine, we all rolled that out very quickly. And at City of Hope, I've been working on remote consults for a while, but actual video-based telemedicine has been a much newer enterprise, and it was catalyzed incredibly by coronavirus. Things that were going to roll out over 6 or 12 months suddenly went out over 2 weeks. And yeah, it was a big change. But we were all trained in bedside manner and our patient interactions. I mean, we've experienced that since we were pediatric patients ourselves. We've all trained all our lives in interpersonal connections face to face, and we've had 3 months of very concentrated experience of screen-based interactions, including what we're doing now. In the past would have largely been in person because that was what was done. And of course, we have very little experience in telemedicine and website manner. Do you think that that's going to get much better, or is it just an inherent low ceiling in the platform in general that will make it always a poor substitute for deeper interpersonal connections?
Yeah, I wouldn't use the word poor substitute. It may just, for me, I think this is a question that may get different answers depending on who you talk to. For me, I really think that the ability to relay information, I've been shocked at this, because if we would have talked, I was confident 3 months ago that this wouldn't be that big of a deal, that yes, there would be some challenges, but I think that there's a low ceiling here for telemedicine, and I'm willing to continue to push it and see how high it can go. I just am drawn to so many stories over the past 6 weeks, specifically with new patients, trying to get a shared decision-making going, trying to understand goals, trying to understand their perspectives. Remember, oftentimes these patients, when they do come in, they bring family members that don't live with them. And so when you're talking to them through telemedicine, oftentimes there's not the capability to bring them in routinely, although we should. We've had challenges doing a 3-way in terms of another family member coming in or being at the home when this happens. So, this is,
translators, has that been okay, or has that been a problem?
The translators, actually, believe it or not, have been okay. It's just that getting other family members on the phone is sometimes challenging. And, one of the beauties, I believe, of this field is it's a family affair. It's not just a, one-on-one discussion. It's a discussion that is, that patients bring their families in on. They're critical decisions. And I've had a hard time having a real flow with patients sometimes, especially when we're talking about advanced stage lung cancer patients, where treatments are nuanced, outcomes are different based on genetic information. I mean, not only is there information overload, but there's the goals of care. And I've had a harder time, and I don't know, from my perspective, there may be a low ceiling for telemedicine on that one.
I think it's both. I think there's components that will never get better. I agree with Ben quite strongly that it's never going to be the same as being in person. But I do think there are things that could make it better that haven't quite gotten there because of limits in technology. And as Jack said, how quickly this has come to pass. For example, the biggest barrier in my conversations overwhelmingly has been the bandwidth question. If I can't understand, if I'm struggling to hear your every word or your every other word in terms of what you're saying, then it's hard to even start to develop rapport or get to the core issue. Right. It's such a big barrier that it's almost hard to get to the other refinements that I think you're referencing, Jack. And some technology improvements will get us there. Maybe as 5G rolls out, there'll be a democratization of broader internet. Maybe there are solutions. Patients maybe need to park in the parking lot of their local library that has broadband. There are organizations that have put out lists in different localities of where you can actually do this, and telemedicine has been part of their target. Personally, I don't feel terribly comfortable telling a sick cancer patient, go park at I've looked up your locations, go park in your local Walmart or library or whatever it is and call me. It doesn't quite feel right. But if somehow people could get better bandwidth, it would help. People talk about Zoom fatigue. Even the three of us talking here, there's not a great sync between voice and lips moving, and that makes it even a little bit harder. Again, technology could help with that. We're all new to this. I have the hope as Jack suggested, that as we do this longer, as our patients do this longer, as society as a whole does this better, that we'll learn a little bit better how to connect via video. But I also agree with Ben that even if all of that were implemented, there's still a ceiling of how high this can get, where there's nothing like being in person when you're trying to connect with someone and deal with really challenging issues together.
And I agree with that. I would just say that, one of the other issues is for us, we're able to do this with relative convenience, even if it's imperfect, compared to the complete infeasibility of flying to a place together to talk for an hour in the same room. And so it's a bit like the comments about when phone-based cameras came out and largely ended up replacing your actual camera. This is not a medium format camera for art that people carry in their pocket, but they say also the best camera is the one you have with you. And, to the extent that telemedicine makes it possible to do some things that might not be possible.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.